Good afternoon. Welcome to the National Center for Interprofessional Practice and Education's webinar on expanding a successful interprofessional approach with a strong community partner. This afternoon's webinar is presented by the Arizona's Nexus team. This is the 7th in a series of monthly webinars that are scheduled to go through this July. This webinar, as well as every previous webinar, has been recorded and can be accessed on the webinar on our website.
Hello, this is Angela Wilson. I'm the National Center's Interprofessional Continuing Education Manager. And this webinar has been accredited through the National Center, which is a jointly accredited provider of interprofessional continuing education credits. The profession-specific credit that's available is listed on this slide, and all professions are eligible for interprofessional continuing education credit for this webinar. Continuing education is only available for this webinar for an optional fee, and if you have any questions, feel free to contact us. The National Center also has a conflict of interest policy in association with our jointly accredited provider status, and this slide goes ahead and lets you know that all of the presenters have declared any conflicts of interest and none of them had anything to declare.
My name is Carla Dieter, and I will be facilitating this afternoon's webinar. And I am the coordinator of the Accelerating Initiative program and also the coordinator of the Nexus IPE programs. Next slide. Our presenters this afternoon are Liz Harrell from the Edson College of Nursing, Health, and Innovation at the Arizona State University, Oakley Rogers, Department Chair and Associate Clinical Professor of Occupational Therapy at Northern Arizona, and Terry Kennedy, previously at Arizona State, but currently the Associate Dean for Interprofessional Practice, Education, and Policy Research at the University of Kansas School of Nursing. Next slide. Our objectives for this particular presentation, as well as all the previous ones, are listed here on the slide, discussing how the Nexus IPE team was able to implement their academic practice partnership, describe how the team of students and health professionals actively learned and worked together, and discuss key lessons and describe the application of at least one IPE learning program system tool. And this afternoon, 2 tools will be highlighted. As with all of our presentations, we are just listing for your refreshment the interprofessional education definition, as well as the National Center's definition of the Nexus, which includes healthcare education and healthcare delivery must be simultaneously designed to be better integrated and more interprofessional while demonstrating outcomes. The Accelerating Initiative was an initiative that was initially funded by 4 private foundations in 2016, the John A. Hartford Foundation, the Robert Wood Johnson Foundation, Josiah Macy Jr. Foundation, and the Gordon and Betty Moore Foundation. They came to the National Center and with a vision to advance the 2010 Future of Nursing Report, which outlined major recommendations for the role of nurses in the development and leadership of emerging collaborative care models. So these partners supported the National Center to coordinate a one-time program which was titled the Accelerating Interprofessional Community-Based Education and Practice Initiative. And the 16 nursing schools were chosen through a national call for proposals. They did have to have 2 community settings. It was a 2-year cohort. They were awarded $50,000 plus significant technical assistance from the National Center for 2 years. The sites needed to match with a $50,000 match, and we included in our significant technical assistance was an institute, many tools, a site visit, monthly group calls, and we also had an external evaluator, Harder and Company, that evaluated all of the outcomes from this program. So please visit our nexusipe.org website for more information. This webinar in one slide. This is typical of what we've been doing. The future is interprofessional. The key is community and practice. The focus is really on the people, patients, clients, families, and communities, not the professionals and the students. The difference is the nexus, and we've already discussed what the definition of that is. The approach that Arizona took, the community needs were the cornerstone to guide their work. Value and alignment with education and community partners was important, and they launched from an existing successful program called SHOW, and you'll be learning more about that. Outcomes are listed here not only for the community partner and their residents, which was Crossroads Incorporated, but also students, faculty, and Crossroads staff, and so everybody was meeting their goals of learning and health outcomes. Key lessons of Arizona are also listed, and the two Nexus IPE learning tools that we will be discussing today are the stakeholder analysis and the micro, meso, macro, or M3, and aligning your Nexus through a systems lens. And now I'd like to turn the presentation over to Arizona, and Dr. Liz Harrell will start the presentation.
Hello and good afternoon. In 2013, the Student Health Outreach for Wellness Community Initiative, also known as SHOW, was developed to leverage the opportunity presented by all three state university health professional programs that had moved to the downtown area in Phoenix. We saw a unique opportunity to collaborate and address homelessness in our community via a student-run, real-world experiential learning laboratory. At that same time, Crossroads, Inc., the largest residential substance use provider in Arizona, was undergoing a transition from a halfway house model to a state-licensed treatment provider. Moving from the self-pay halfway house model to an insurance reimbursement model meant Crossroads had to meet new state licensure and access, which is our Medicaid here in Arizona, their requirements. One of which was the completion of health assessments 7 days after admission. Crossroads looked to academic partners across the valley to help. One of SHOW's first organized activities was the completion of those health assessments. It soon became apparent that Medicaid recipients had more complex care issues than the self-pay population. And so in 2015, Lee Piowski, the CEO of Crossroads, approached me asking for more. We discussed the development of an interprofessional direct care service pilot. The National Center's Accelerating Grant Call came within months of that ask. Next slide, please. CAPER, housed in the Edson College of Nursing and Health Innovation, which stands for the Center of Interprofessional Practice Education and Research, encouraged SHOW to apply and took lead in writing the grant. There were 17 members in total on the project, but for the purpose of this presentation, we want to highlight the grant writing team, the health promotion and healthcare team members, and the community practice stakeholders involved in the project. Once notified of the award, I gathered SHOW leadership, Bonnie Irwin, Oakley Rogers, and reached out to additional leaders in the Doctor of Nursing practice and PT programs to help shape practice. I also included student voices to represent that perspective. Jeff and Carol joined the team as preceptors, and with Crossroads Quality Improvement Manager, 3 teams were created: the healthcare management, health promotion, and leadership development teams. For this webinar, we will focus on the health promotion and care teams as they focused on the community partnership, while leadership explored student competency gains. Next slide, please. The grant writing team did an excellent job of listening to all stakeholders and crafted a compelling vision. The whole grant team started with the need of Crossroads residents and the Crossroads organization first as the cornerstone to guide the work. Students were a way to add value and provide a service to Crossroads residents. The vision shaped the stakeholder analysis. In 2016, planning began. We first started with the Crossroads patient needs assessment. The patients identified needs, which were then grouped into 4 top concerns: mental health, primary care to address chronic conditions and infectious diseases, health literacy for health promotion and prevention, and occupational and social concerns. Health promotion and direct care teams were created and then launched to address these specific needs. Crossroads as an organization identified enhancing the care for residents with complex care needs, thus improve outcomes while keeping costs low as their main goals for the pilot. All wanted a meaningful information exchange. We worked together to develop metrics guided by the triple aim. Quality care was measured by length of stay and incident reports. The patient experience was measured by patient satisfaction, and costs were measured by value of investment. The academic partners identified wanting clinical experiences in response to the opioid epidemic. Clinical experiences at Crossroads would help to meet social determinant of health course objectives across all health professional programs and address population health beyond what is typically provided in healthcare education, specifically IPE and substance use treatment competency acquisition, awareness of impact of ACEs, need for trauma-informed care, and to reduce stigma. Next slide, please. By blending the missions and goals of Crossroads residents, the Crossroads organization and the university educational partners developed a common vision that fit all stakeholders and addressed 2 of the Accelerating Initiative Grant selection criteria: creativity of the initiative and its potential to accelerate interprofessional collaborative practice in community settings, and demonstrated collaboration with the community partners, including how the initiative meets the community needs. There's a visible connection between the partners that verifies the written vision statement was more than just words on paper. And these are the health management team outcomes. In spring of 2017, outcomes were measured and the health team outcomes are presented. The direct care team had seen a total of 100 client visits by the time of the analysis, although the overall pilot had 602 client visits. 2 pilot facilities were compared to 1 treatment as usual facility that had comparable population demographics. Quality care, as measured by length of stay outcomes, showed clinical significance. Crossroads site number 1 had a 6.2 increase and Crossroads site 2 had a 1.7% increase in Crossroads residents' 30-day completion rates after the implementation of the IP health management teams, while another Crossroads site serving as the control site had a 3.6 decrease in 30-day completion rates during the same time period. This was significant to Crossroads because individuals in early recovery often have trouble coping with routine physical symptoms. They tend to overutilize or underutilize level of care to their physical health symptoms. The use of substances numbs their perception of physical symptom severity, and so they have trouble gauging how bad or how minor their symptoms may be. And if they leave the structured environment to go to urgent care or the ED, potential for relapse skyrockets. Just this past month, a resident died after leaving Crossroads to visit her dentist. She was found in an alley behind the dentist's office after an overdose. Statistical significance in medical incident reports was noted. There were 0 medical incident reports in both pilot sites, while medical-related incident reports continued in the treatment as usual site. Provider satisfaction also increased, although not formally measured by Crossroads staff. I want to read a quote from the Harder and Company case study. The Crossroads approach to substance use treatment, which relied on peer support, differed from the academic and clinical approaches of its Nexus partners. Yet the team successfully bridged differences by working towards common goals and valuing everyone at the table equally. A Crossroads employee identified the shared goals, saying everybody wanted the residents to come first and their health to be looked at and addressed so that they could recover. Another added, when we became mindful that this was not about your position or mine, it's about the residents and what's going to help this person stay sober and complete their treatment, things would fall quickly into place. A community partner noted that the natural tension between academic and direct service cultures had resolved into a sense of mutual gain. Not only did we see the benefit of having a professional and academic world come into our organization, he said, but the academic and education world see the benefit of what we bring to the table and that community involvement. This success was again due to a careful stakeholder analysis that took into consideration needs from all perspectives and also to an interprofessional approach. Crossroads staff were a part of the care delivery team. The health management team took their input very seriously, and their input was given the same weight as all the other members of the team. Finally, value of investment was better understood by all. Based on how much it would cost to employ just the preceptors for the time they were on the site, Crossroads realized an $83,000 salary savings for $95,000 of clinical services provided by the teams. Next slide for Oakley, please.
Hello. So I had the opportunity of working with the students for the health promotion, and it was the occupational therapy students, physical therapy, and social work students. We had the opportunity to bring the students together to orient them in an interprofessional orientation where they could learn how to work in a team and also what the expectations were of them when they partnered with Crossroads. After the students completed the orientation, they had an opportunity to further develop that stakeholder analysis, and they completed a comprehensive needs assessment where they got input not only from the employees of Crossroads, but also the residents of Crossroads. After learning the needs, they developed their programs and implemented it. After that implementation, they also evaluated to learn and understand the effectiveness of the programs and to ensure that it would be sustainable when they left. They were no longer there. There were a total of 25 students who participated at the 2 pilot sites, and over 400 residents participated in these programs. The programs that the students developed and implemented related to health and wellness, vocational training, stress management, and family education, just to name a few. This opportunity added to the typical programming that Crossroads was not able to offer without having these health profession students. Not only did the students create these programs, they also gave an opportunity for the residents to learn additional skills and how to manage their own symptoms as they went through the recovery process. Next slide.
Both the health promotion and direct care teams were consistent in starting with the needs of patients and the community organization, then developed the student experiences. The stakeholder analysis guides this process. The stakeholder analysis tool helps teams identify current and future stakeholders and determine how both the stakeholders and the team can benefit from and add to the success of the Nexus program. The purpose of the tool helps teams identify current and future new partners that could be affected or benefit from your Nexus work. It is important to identify all who will be impacted, including those who have power and influence over the work, either providing support or barriers to your work. Through identification of stakeholders, it gives you the opportunity to win them over. Moreover, the information can be used to identify possible stakeholders to include on your team and/or develop new or strengthened relationships. It also helps ensure your vision for your Nexus aligns with stakeholders and how the team can bring success to benefit all. There are pros and cons. A pro is the ability to change thinking and strategically engage stakeholders. A con is team members may not be able to easily identify what is important to each stakeholder. Thus, it may take additional time to either find out and/or include additional members to help. What not to do with this tool? Teams that do not adequately identify all stakeholders and what is important to them often fail to recognize important influences or resources that could benefit or block their work. Teams miss out on important information to advance their work and opportunities to develop strategic relationships. It's important to note that the analysis is not a one and done, and we will give an example of why reassessment of stakeholders is necessary even after setting up a successful Nexus later in this presentation. Lessons from experience. Successful teams engage participants from all roles in practice and education affected by the program to help complete the tool, allowing for a more comprehensive list. Identifying stakeholders with powerful influence, including leaders inside and outside traditional organizations, not only advance their work, but help garner relationships with other leaders and organizations to accelerate their work. Lee Piowski, the CEO of Crossroads, stated, "It's the first time anyone had ever asked what our needs were and how we could help you." Next slide. This slide provides an example of our earliest stakeholder analysis. Going left to right, starting with Crossroads residents, you can see how the question, "What matters most to this stakeholder?" prompted the need for an assessment to hear directly from them. The next question of how our program could meet those needs guided the creation of the health promotion and the direct care teams. The next question about the creation of a new Nexus led to measuring patient satisfaction and quality of care in terms of length of stay and medical incident reports. And finally, how can each stakeholder's new role and job help make the Nexus a success? How can they play their role and be engaged, guided our workflows. One example of that was a weekly huddle for participants on the direct care teams, including the Crossroads staff. Next slide for Terry, please.
Thank you, Liz. Hi, this is Terry Kennedy. I am going to give you a sneak peek at a brand new tool in the National Center's toolkit. We call it the Micro, Meso, Macro, or Aligning Your Nexus Through a Systems Lens tool. For short, we'll call it the M3 tool. And I'm going to use some examples from the Arizona Nexus team to help us walk through the tool. So the experience of the Arizona Nexus team, as well as the other accelerating sites in this webinar series, really reinforces that the work of academic practice teams or Nexus teams occurs within a complex environment. As you can see from the illustration on this slide, this includes 3 levels. The microsystem level is our immediate working environment. The mesosystem level is the larger administrative and organizational environment of our academic and practice organizations, respectively. And then the macrosystem level is the broader political and institutional environments in which we live and work. So the M3 tool explores these environments through a systems theory lens. The tool was developed to help our teams understand the relationship between and the influence of all these environmental factors on our collaborative partnerships, with the eye towards facilitating success and sustainability of these partnerships. So by understanding these forces, we can better identify some opportunities for alignment between our academic and practice teams. And this can foster forging of a solid Nexus team collaboration. So I'm going to walk you through each system level with a brief example from the Arizona Nexus team. so you can see how the model works. So I'm going to start at the micro level, move to the meso level, and then finally the macro system level. And I'm going to talk first about the practice team, then the academic team, and then the Nexus team. So at the microsystem level, again, this is the immediate working environment. On the practice team side, Liz talked about how the Crossroad team members work within a peer guided care environment using a 12-step model. So members of the team are in recovery from substance use and are not required to have a professional education or licensure. On the academic team side, we had the culture of a student-run clinic, so that the university team members have experience working with students who are undergrads and graduates, as well as faculty, while they're working with vulnerable populations. And everyone's contributions are equally valued. So when we bring this together at the level of the Nexus team, the peer-based culture of the Crossroads and the student-led culture of SHOW supported a Nexus team collaboration that ended up having a flattened hierarchy. And what that meant was that the role played by each member was valued and each member was viewed as an equal partner. So now moving to the meso system level, again, this is the larger administrative and organizational environment. Starting with the practice team, there was a focus with the Crossroads on the importance of facilitating access to quality healthcare and reducing costs. So wanting to make sure that the agency was better serving their clients. On the academic team side, the senior leadership of the university valued community-embedded programs and they valued use-inspired research. So the model that SHOW had provided as a predecessor to the Crossroads, Liz had demonstrated successfully applying these values. And so the meeting at the Crossroads provided a further extension of the model while advancing interprofessional learning for students. Now, putting this together again at the Nexus team level, what we saw was that while focusing on the needs of agency clients first, agency staff experienced informal learning just by the presence of the faculty and student teams working with them. And they were advancing interprofessional learning for both the current and the future workforce simultaneously. The other thing that Liz talked about through the comments of care team members is that this collaboration improved the experience of providers, so it actually got to the quadruple aim as well. And then finally, at the macro system level, this again is the broader political and institutional environments in which we work. On the practice side, we understand that there was this transition from a regulatory and payment environment that required the Crossroads program to assess and address the complex care needs of their clients. On the academic team side, we had a 2016 Institute of Medicine report that brought national attention to the impact of social determinants of health. And the report was recommending that health professionals have access to education that builds critical thinking through interprofessional, cross-sectorial, experiential learning, going from foundation through continuing professional development. So again, bringing this together at the level of the Nexus team, specific to this collaboration, there was an opioid crisis occurring within Arizona as there was nationally. And this put a spotlight on the importance of effective substance use intervention, and it perfectly positioned the Arizona Nexus team to address Arizona's top public health priority, while also addressing the complex care needs and social determinants of health of Crossroads clients. So students learned about social determinants of health and complex care needs, as did the staff of the Crossroads. So again, through these examples of the Arizona Nexus team, it shows us that we can intentionally align and co-create a true nexus by understanding the macro, meso, and micro, meso, and macro context of our academic and practice partnerships. And by working together, we can co-create a true nexus partnership with a very distinctive profile. So I'm going to turn it back over to Liz.
Thank you. The health promotion and direct, next slide, please. The health promotion and direct care teams were so successful that Crossroads committed to building their own integrated primary care clinic. The idea was to create a faculty practice model that both billed for integrated care, but allowed for services not covered to be given free of charge to clients by the interprofessional student teams. This organizational change, the addition of a fee-for-service line, strained Crossroads' capacity for rapid change, and they became concerned SHO was going to somehow compete for revenue dollars. Because they were new to all of it. Imagine moving from only billing for one residential bed code to hundreds of service codes connected to fee for service. They understandably reacted by pulling back and asked SHO to pause. It was a confusing time as they didn't have the experience or the language to explain the position, and in retrospect, it would have been the perfect time to do another stakeholder analysis. Luckily, the strong relationship, the Nexus partnership, and my dual role as a medical director allowed this situation to be ultimately seen as a positive, as it could have made the relationship fall apart. Once it was understood that Crossroads was starting to think about a massive service delivery change, and thus the potential for competition for revenue in any way, shape, or form was magnified, I could begin to help navigate. Crossroads has 400 residential beds to date, and the market in Arizona is saturated. They are shifting new growth towards integrated primary clinics and outpatient services. New clinics will be built out that are connected to outpatient services. These new service lines will then refer to existing beds within the Crossroads organization as the patient needs. My dual role allowed me to think through what Crossroads may need to coordinate care as patients transition through the service lines, and how students could actively support Crossroads while also benefiting from the experience. For Crossroads, this meant the development of a new integrated service line manager, and for students, this meant the potential for developing a hotspotting-like team. New slide. Next slide, please. Oh, you're there. Sorry, go back. I got confused. So, meaningful changes in practice resulted in system changes and increased access to care. So since 2018, we have worked together to plan a new integrated primary care clinic. A women's health nurse practitioner was added as a new member to the team in direct response to health needs of women who use substances. And that Mesa clinic opened in January 2019. All the insurance and credentialing plans were finalized, and the practice continues to build its patient panel. In February, we saw almost 600 patients. A community medication coordinator was identified as a need, and a partnership with Genoa Pharmacy was identified, and we are well into planning about what that will look like, which will help us with medication management. As mentioned, the integrated care manager position was developed, and it will align and coordinate all three service lines. An IP treatment planning group with Grand Canyon. These are undergrad nursing programs with Grand Canyon, Aspen Nursing, ASU Nursing, are working on building out an interprofessional treatment plan that will follow patients through all services within the Crossroads organization. And they are also working on interprofessional training modules, such as motivational interviewing for the student groups. We're also including MAT services and telehealth to our services. And our adult nurse practitioner, who is also the medical assistant, has entered ASU to get her psych certification. Students and faculty are continuing to add value to the clinical site, resulting in system changes as well. New infectious disease screening and treatment protocols were developed as a result of a DNP student applied program, and a DNP student applied project on Hep C resulted in Crossroads adding a laboratory to a new Phoenix integrated care office at the corporate building, which will identify infectious diseases at the time of admission, providing a unique opportunity to start treating individuals at the time of residential service admission, as opposed to them us waiting until they got referred into the clinic. And that their average length of stay is 45 days. So we have a very good treatment window there. The majority of providers at SHOW providers at Crossroads are SHOW preceptors, so they're knowledgeable in interprofessional practice and active in incorporating students into their practice. So although at this point in time we're not interprofessional, we plan to make these clinic future IPP training sites. And so we are focusing on rebuilding interprofessional student experience in the new context, that hotspotting model to follow patients through all service lines and into the community. Next slide, please. So some key lessons. Relationships matter. It was the right relationship for the right time and in the right place. In Crossroads, you have an organization that was seeking out help and hungry for change. They're incredible for letting us come into their facilities and partner with them as a learning laboratory. They have seen the benefit, and it's been a synergistic partnership that has been thrilling to watch grow. The Harder & Co. Case study noted, a community partner likewise expressed appreciation for the ability to have students and related faculty members help us achieve things we would never have been possible for us to achieve. And that means new programming, new skills, not just the bare bones physical health treatment. This Nexus has led to continued expanded services, the integrated care clinics, the service care delivery model, QI projects. We have 10 additional DNP students who are focusing on overdose prevention and aftercare of an overdose for staff. Another key lesson was guided interprofessional practice learning experiences are key. A community-based experience, in short, adds value to interprofessional learning. Again, the Harder & Co. report states, a Nexus partner commented, we don't want interprofessional education to end at the classroom door. We want to make sure that we're advancing it in the community. This program is an exemplar for our university in terms of best practice for interprofessional education, and that it's community embedded, community engaged, community focused. Patients are a future workforce that must be ready to take on social challenges. Student participants observed firsthand the effects of opioid addiction and other substance abuse. They also learned the difference they could make as part of an interprofessional practice team. For faculty, preparing students to thrive amid real-world complexities was central. As one put it, we encourage our students to flex their leadership muscles. We try to give them opportunity to learn some models of managing ethical dilemmas, not shying away from challenges in practice, but being prepared to hit them quickly and think on their feet. Next slide, please. Throughout, the National Center has given us the structure needed to organize our experience and the feedback needed to validate, and therefore the motivation to continue building on what was working. This work is challenging and can be downright hard, but with support, the benefits are attainable and richly rewarding. Without this opportunity, Crossroads and the academic partners would not have engaged as meaningfully or as in-depth with each other. We would not have created a Nexus. We would not have had the tools to shape and articulate our outcomes. An example of positive feedback, which is also a Nexus tool, is the National Center's ACE 15. In November 2016, our assessment showed the greatest strength in areas of the team culture, of continuous learning, appreciating each other's values and diversity, roles and expertise, autonomy, and ability to bring up concerns. It is evident the team is good at challenging the process and the status quo. No one in our team would have been able to identify these strengths so eloquently or in such a quotable way. This feedback is so important to support work to stakeholders across care organizations and academic leadership across universities. One last point I would like to make. When I reconvened the original grant team that participated on the health promotion and direct care teams to ask if they would like to rebuild a hot spotting student experience at Crossroads, every single one of them said yes. They all see the potential. What learning opportunities this new direction brings to our students, how we all can contribute to Crossroads because we all care about this community and the organization, and how we all miss working together as a team. Thank you. Next slide.
Thank you, Drs. Harrell, Rogers, and Kennedy. It's been wonderful to listen to your Nexus program and how it has evolved and grown and matured. And the thing that I want to emphasize, as Liz has throughout, is that their relationships mattered, that they were all partners were meeting their goals, both health and learning outcomes. And while they've had to take a pause to help the full understanding and the to help Crossroads and their clinics get on their feet with this new model that they've never implemented before. It was not a stoppage, it was a pause. And they are just redesigning and still, excuse me, still moving forward. So that's important. Liz talked about the critical events. They had several, and last month's webinar talked about the critical events tool and how important that is to really identify what's going on during your programming. The critical events are normal. Things happen. And it's how you pivot and learn and when you get stuck, what do you do with that? And the Nexus learning system is a way to scaffold that, and the tools that help the teams really continue to implement and focus on learning and health outcomes. Next slide, please. Want to just remind everybody that this webinar series continues, and the next 3 are listed here. Next slide. And this is our website. If you go to nexusipe.org and click under Advancing and click then on the Accelerating Interprofessional Community-Based Education and Practice, there's a lot more information, many resources there for you. And now I'd like to open it up if there are any questions or comments that any of the participants would like to add. One thing I would like to emphasize, and Liz, you and Terry both emphasize this a little bit. I'm just going to bring this one last point up, is that really throughout the program, not only were your students learning, but the workforce at Crossroads was also learning. And if you'd want to add any comments regarding that, as far as really you were educating both the future and the current workforce, and how that came about, that might not have initially been planned, but it certainly did come through. Do you have any other comments, either Liz, Terry, or Oakley?
I can make a comment on that. This is Liz. The 12-step community can be very suspicious of healthcare providers. They have not had very good reception in the healthcare world. There's a lot of stigma and a lot of blame when they encounter healthcare professionals. And so from the beginning, I was conscious of that stigma and how to create something that would overcome it. And so adding the Crossroads staff onto the direct care teams was one major way to combat that. I knew that if we could become a true, work through the stages of team development and become a true team and get comfortable with each other, that would spread. It also, on the other hand, took the health professionals on that team. We needed also to be understanding of their environment and realize that we were not in a hospital, we were not in a clinic, that we were actually in their home. These are residential facilities. And so we need to relax a little bit about how we approach things, which was a learning on our part too. So I think being open to allowing us to learn and then, allowed any potential defenses to be reduced and allowed for just what you were saying, Carla, for that to that relationship to truly develop. Oakley, did you have anything to add from your perspective?
I think the only other thing to add is I think that's a very important point. When the students were for the health promotion, when they were working to complete that needs assessment and all throughout their implementation and evaluation, the staff, they were very involved throughout that entire process. And through the collaboration between the students and the staff, they worked together to identify how could it be sustainable. So then that way, when the students left, that Crossroads would still be able to use the resources and tools that the students developed. And it's neat to see, even going back to Crossroads now, how they still, bring out those resources and utilize them in their own sessions. So that's a great point to highlight.
This is Terry. I was just going to comment also that sending students in to work with adults with substance use disorders, oftentimes students have stigma that they bring into those situations, or sometimes they have personal baggage that they bring into those situations that they may or may not yet have addressed. And one of the things that I think was really successful was hearing the students talk about how a lot of the stereotypes that they had formed about people living with substance use disorders had really transformed. And I remember a student at the site visit talking about how this was now going to be the field that she wanted to pursue when she graduated, and it was a really dramatic statement from her. She had said this was the last area she thought she'd ever want to work in, and she said, now I don't want to work anywhere but a place like this.
Thank you, all three of you. We're very pleased with your presentation and the ability to really discuss what's happened and the growth and maturity of your site. So I see, Sean Diego, I'm not seeing any questions right now, and if not, then we will wrap up this presentation and look forward to seeing everyone at the next time.
Thank you.
Thank you. Bye.
Thank you.